will be Dr. Blessy Rachel. Let me introduce her to you. She did her pharmacy from Pushpagiri College of Pharmacy, Kerala, and then she worked as a clinical pharmacist in Pushpagiri Medical College Hospital and clinical pharmacist in Believer Church Medical College Hospital and drug safety associate in IQVIA worked for Johnson & Johnson, and currently she is a pharmacology faculty at MidCity International Academy. And today they both will be the judging panel. Welcome you both to our session.
Thank you. Thank you so much for the warm introduction.
Thank you.
Welcome, ma'am.
Thank you for the introduction. Yeah.
And okay, and then with no further ado, let's move on to a competition. Let me read out the rules and regulations. Um, I'll be reading out the participants by the your slot number one by one. When it's your time, please unmute yourself and you can share your screen and start presenting the PPT that you have submitted through AIRPPC link. And the presentation time will be 5 minutes and 2 minutes for the discussion with the panel members. Hope you are clear with the rules. And with no further ado, let's move on. This is the competition of All India Research Paper Presentation. The first lot will be Deepak Kumar Puna from College KVK College of Pharmacy. Deepak Kumar, the slot number SYCCONRX S48001. Slot number 1, Deepak Kumar. You can proceed with your presentation. Deepak Kumar, we can see your screen. Please unmute yourself and start presenting. Slot number one, Deepak Kumar, can you hear us? So, moving on, if Deepak Kumar comes back, he'll be presenting. Now, moving on to slot number three. Slot number three, N. L. Shwati from Sri Venkateswara College of Pharmacy. Slot number SYCCONRXS48003. Yan L. Shwati from Sri Venkateswara College. And all the best. You can go forward.
Yeah. So, hi everyone, this is Swati. Allow me to introduce myself. Hope you're all doing good. And I'm a PharmD final year student. I'm working as a writer and as well as research assistant. Today, I'm going to share a presentation of our research which we have done during our fifth year. So, let me know once my screen is visible. Yeah.
Yeah,
So, is my
Shwati, your
screen
screen is
visible?
visible.
Yeah, and if you have
Yes, it
any
is.
type of questions, you can stop me in middle, and I'll try to be in 5 minutes gap. So the holistic approach is our main theme doing our research in creative. So we have created a title which is the impact of individualized interventions on diabetes and glycemic outcome, a quasi experimental analysis. So these are the contents we are going through. So the introduction, which is like I'll short it up. So diabetes mellitus is not only a certain disease, but it also constitutes a various multiple etiologies which can turn into microvascular damages and macrovascular damages. So on the right side, you can see the images which can lead to the diabetic complications, which includes PKC, beta activations, and by the formations of diacylglycerol. So the main focus on this research is like why the diabetic people under numerous drugs are also but not under the suboptimal range but not under the optimal range of diabetes levels. So let's say we are giving whatever the drug metformin or glimepiride, the drugs we are giving to the patients, but next visit the patient should be under the HbA1c level or a sugar level normal level, but the patient is increasing his HbA1c levels. So our main initiative is like what is the other factors which can make the patient to make the diabetes in suboptimal range. So we found one of the most thing is like uh, diabetes distress. So it is a specific distress only related to the diabetes, which is like so we have various types of stresses, which includes psychological stresses like stress types of work related, life related. But I have heard a term called stress which causes to arise only because of diabetes. So this type of stress is called as diabetes distress. So as you can see here, wait, this is the pathway we have followed during our research. First, we have arranged a normal meeting with the patient, and later on, we made awareness what is diabetes distress. So we can't verify a patient whether he is a distress due to diabetes or distress due to other circumstances. So we have ruled out a questionnaire, which is a combination of paid analysis, like problem assessment area in diabetes, and also UK pyramid of diabetology. So we have made combined of these two things and made a proper questionnaire. This questionnaire helps us to rule out whether the patient is psychologically stressed enough due to diabetes or not. And after that, what we do is like checking his diabetes distress score and also his HbA1c level. For this, we have changed it to RBS levels. So let's say his distress score is around 30 to 45 and his RBS score is 300. Then we take in that kind of patients. So this is a short intro of diabetic distress. And so to be precise, in type 2 diabetes, we have chosen only type 2 diabetes people because of the vast prevalence. In the first graph, you have seen that the diabetic prevalence, the type 2 diabetic prevalence rises among 382 million in 2020. So due to the prevalence of type 2 diabetes mellitus, we have chosen only the diabetic distress people along with type 2 diabetes. And what we have done, so we sort of doing an interventional study rather than an observational study. For the interventional study, we have thought various types of study methodologies. Among them, which is quite suitable with our studies, quasi experimental study. So for that, we have included pre and post data. In the pre data, we only include the diabetic distress score plus their RBS levels. So to get the post data, we included certain factors, which is like we will counsel them psychologically how to reduce the diabetic distress levels. Again, we are going to include lifestyle modifications, which includes the diet, which is the most common thing, but also the crucial thing uh, in our research. So let's say the diet is not only a food item, but it can, if it is used properly, we can make wonders and miracles of it. This was a main motto. Along with the medications, we also sought to make some other differences so that we can make the diabetic level to come to the optimal range rather than the suboptimal or over optimal. So let's say our proximal factor to consider the diet is due to diabetes mellitus. In the diabetes mellitus, we are giving the disease introduction to them and knowledge, lifestyle, diet management, all this stuff. So the digital factor, what we are going to do, like what is the anticipated outcome of the digital factor. So we are trying to reduce the RBS levels and also as well as the macro and microvascular complications of diabetes. So we have done a literature review to find out whether this idea is possible or not. So this was the results, which says that there was diabetic distress was seen. As you can see, this second one, they have seen the depression and distress in diabetes. So these says that proof the diabetic distress is allowed in the diabetic conditions. And these are all like various studies which says that they have done diabetic distress program and they have done diabetes management. So we are like we have combined both the things, diabetic distress and as well as diabetic management. And this study gave an approach to how to diagnose and how to qualify the patients according to the distress score. And I've said it previously, to bring the patient to this optimal level of sugar management and also as well as to reduce the macro and microvascular complications. If a person with diabetes in 5 to 10 years, he might also develop cardiovascular infections or risks. So we are aim to try those, reduce those levels. And we have said this previously, and the methodology, it was on quasi experimental total of 6 months. And initially, the sample size was 180. But on the follow up period, we have some random errors due to the inexplicability of the patient's data and the patient's inexperience, all this stuff. So, what type of people we have included? So, he should be under type 2 diagnosed, that also uncontrolled diabetes. You're not taking any other controlled diabetes cases, only uncontrolled type 2 diabetes peoples and diabetes with cardiac problems, let's say like HTN and DLP, like this only. And we are going to include only 18 to 65 and ICF, informed consent forms only. So why I'm taking only OP patients, that is outpatients, because our main motto is when a patient is healthy enough only, we have to make them more healthy. So if a patient is IP, you're not going to consider all these psychological stress levels. No matter how much we counsel them, the stress levels of an IP patient who is under diabetes will be having some sort of stress. So that's why we have neglected the OP patients and we have chosen OP patients. And the exclusion criteria includes gestational diabetes and whatever type of diabetes and severe comorbidities like septicemia, and cerebrovascular accidents. We excluded all the types of comorbidities and the patients on insulin. Why we have neglected the patients on insulin means it's a protein which can be interacted with the diet which we give, or also some sort of psychological counseling. So we have neglected those patients, and we have performed SPSS, and these are the anticipated outcomes of this study. So like this we have performed. So first we have literature and protocol we have submitted to the ethical review committee, and checklisting all was done. And initially we have 180, and later on in this we have divided according to the patient's choice only, because quasi experimental study methodology allows us to choose the patient whether they want to be in the control group or in the experimental group. In the experimental group only we are going to give this diet counseling and also the psychological counseling and exercise counseling. So because if we ask the patient to be in the experimental only, to be in the control only, this might be the other cause of the stress levels to increase in the patients also. So that's why we left this option to the patient itself. They can be under control or experimental based on their will. So for the control people, we are not going to do anything. We are just going to assess their DDS score, and DDS in the sense diabetic distress score, DDS score and the RBS level before 3 months and after 3 months. This is only for done for control people. And what we have to go for the experimental people, we are going to take the DDS score as well as RBS score, and we are going to make a call for them. Let's say these are the diet you have to follow regularly, and you have to come for these are the psychological counseling we are going to give on the day of the hospital visit only. And we are going to make a intervention call during once a month. So we have made 3 calls, and we have, according to the responses gathered these 3 months, we have collected the DDS score and also the RBS score after 3 months. So we have gathered all the statistical analysis. And so in previously I've said according to the DDS score, we have divided the patients, right? So for that, let me show you the this question. The questionnaire is not available, but we have around 29 questions. For that, the rating will be like 0, 1, 2, 3, 4. If we ask a question, so do you feel any type of problem with the diabetes when you're going out? Then he says, no, I'm not feeling, I'm very life accommodating. Then the patient will be choosing 0. So like that, for the 28 questions, this amount of scores will be given for each question. Later, when he gives the questions answers, we will be analyzing each patient score, like 28 questions each score, and if he comes under 20, then he is under minimal distress scale, and if he is mild distress, like that, according to the score by each patient, we have calculated under minimal, mild, moderate, severe. So this was our gender distribution. One of the major hindrance and major limitations is males are mostly the ones which has been received the treatment, because we also found that there is some gender inequality between the continuation and the also the attainable healthcare equities also. So this was a interpretation of this gender distribution. And as you can see this subject division, so it was like 50-50, control group and experimental group are almost equal. And later on, so we have classified the people. As you can see, this blue mark is the pre-data where we have gathered their DDS score, and this brown mark can indicate the
Swati. Hello.
yeah,
Excuse me, Swati.
yeah,
Are you changing your presentation slides?
yeah. I
Because
have
it
been
was
changing. Couldn't you see
okay.
that?
It was no, actually on my screen it was on six. Now it is changed. It has been changed. So it's fine. You are
Now
on
you can
60,
see.
18, 19, 19 slide, right? I can see now.
Okay, then I'll start this. So we have taken our 28 questions. According to the 28 questions for each patient, we have analyzed whether they are under the minimal, mild, moderate, or severe. Then this was the gender distribution, male and female. In this graph only we can see that the males are the only patient which we can see regularly, and some gender inequality discrepancies as well. And in the subjects division, like whether they want to be in the control or the experimental, we left the choice to them. And we can see 50 out of 50, like the control group and experimental group are equal, so that we can say that these results are valid. And the next one is like, as I've said previously, can you see the graphs clearly?
Yes, it is visible.
Yeah, I'll make a choice on it. Okay, so as you can see this blue data, this blue data includes the pre-data of a patient, and this brown is including the post of the patient. So we have collected the DDS score previously before doing the study. So we for the both control and experimental group. So this was their minimal distress level, like almost 26% or under minimal distress. And after the post distress, we have when for the experimental group. This data is a club of control plus experimental one, and the post data, as you can see, 11 people are only under the experimental group. Sorry, 11 people are only under the minimal distress. So this was following the data. As you can see, the chart has been declining. We sought to understand that our study is somewhat credential, and this was like age division tree data. So
Sorry to
as it
interrupt,
was
Swati. The time has been
okay,
constricting, so please make sure finish it fast.
okay, and this was the RBS mean level in pre and post. As the same indicates, this was divided among control and experimental group. The experimental group, the previous RBS levels mean is around 294, and later without counseling and diet modifications, it was like 260. Even though the incidence is like only 30% of the total relevance, there is some type of we can say significant levels is possible. And this was the box and whisker plot for the pre and post RBS means DDS scores. And we have performed a Pearson correlation value to find out whether there is a relationship between what we are doing and what the result we are getting. So we have analyzed those 26 questions and their relationship between the RBS levels. And as you can see that most of the questions have significance value between the thing we are doing, and this is the total significance. In the post, we have got significance. So it says that our results are somewhat credential. And to be concluded, this was a holistic approach rather than including the medicine. Along with medicine, you should also include the other factors such that the efficacy of the medications will be improved. And this was the appendixes, which is like hospital approval letter, IEC letter, in references for this project, and just form data. And this was the patient information leaflet. We have used this for our projects. And diet plan. The diet plan was made like among four categories, which includes 1,200 kilocalories, 400, 600, and 800. This was given according to the weight and RBS levels of the patient. And this was our active link of a Google form. And we have published a review paper of the same. What is our view on the same? And in the end, medication plus medication compliance is leads to good outcome. Yeah, thank you.
Thank you,
And
Swati. Now over to the panel members' discussion.
Thank you for the presentation, Swati. So, what were the objectives of this study?
the main objective of our study is to bring the people who are under uncontrolled diabetes to the optimal glucose levels, ma'am, with the approach of all the things, not only the medications. And the first is our thing, and the second is to reduce the complications, micro and macrovascular complications.
To reduce the complications. So, was that the objective of the study? That to reduce the
It
complication?
was a secondary objective. If we are going to prolong the study in future, with these results, we are also taking the ASCVD calculator to analyze the risk. And with this subject only, like with this type of idea only, we are trying to reduce the complications, ma'am, as a secondary
Okay,
objective.
but that was not the part of study, right? Uh,
No, ma'am. As for our primary objective, we are going to take to
okay,
reduce the
all right,
uncontrolled to the optimal levels.
all right. Okay, next question is you told that you have counseled the patient regarding diabetes distress and that you have assessed after 3 months, right?
Yeah,
So,
ma'am.
have you assessed the knowledge of the patient that you have counseled to the counseled, like before 3 months and after 3 months, that how patient got the information what you have provided to the to him or her?
Yeah, ma'am, we have graded the patient according to the information we have given. We have followed a patient information documentation form, patient counseling documentation form. Like it will be starting with our introduction and what we do and what the patient understood at the end of the
No,
counseling.
no,
According to that,
not
patient
that.
answered
That
it.
yeah. Excuse me. I got it that you have provided equal information to all the patients, but have you assessed that how much patient got your points? Like, is there
Yeah,
any?
ma'am. We have graded them
Yeah.
according to the responses they gave to us. Like A in the sense one, like that we have graded the responses. So this can verify our counseling techniques.
Okay, and that by which scale you have assessed with this thing?
Normal EQ5D form, ma'am. A quality of life, and also we have used our own college resources for this patient counseling documentation forms.
Okay, okay, all right.
Hi, Shwati.
Hi, ma'am.
Yes. Shwati, can you please explain me about this novelty of this study? I mean, have you seen such similar studies somewhere else or some other countries or even in your own state? Have you come across such studies, same studies or?
Yeah, ma'am, we do have studies which says separately diabetes distress. If we reduce diabetes distress, we can see the optimal level of glucose. And in the diabetes, we need to consider diabetic distress. Like that, we can say each topic correlating to other, but there
Mhm.
isn't any this type of methodology involved, ma'am, currently.
Okay, your methodology is entirely different from other studies, right?
Yeah, ma'am.
Yes. Yeah.
Yeah, ma'am.
Yeah. Have you included any gestational women in the study
No,
or
ma'am.
no?
We have taken only type 2 diabetes mellitus people because we have
Okay.
the prevalence of those kind of diabetes people only in our area.
Yes. Could you please tell me what is the difference between prevalence and incidence?
Incidence in the time, the total number of people affected in a point of time, at certain point of time. Prevalence in the sense, the total number of people affected over a period of time.
Yes, already existing conditions. Yes.
Yeah.
Yeah. Yes. And if you're
What is
including,
the
yes.
yeah?
And
Go ahead, ma'am.
yes. And if you're including questionnaires, no, that will be additionally a plus point for you. Okay. Always try to add that questionnaire at that last portion. Okay.
Yeah, ma'am. Sure, I'll do. If you want, I can
What
share
is
the questionnaire format also right now.
No, no, no. It's okay. Next time you can correct it.
Okay, ma'am.
what is the exact meaning of quasi experimental study?
Ma'am, when we thought to do a interventional study, we don't have that much of knowledge to do randomized control. We don't have that much knowledge to do a randomized control study. So we are searching what are the types of intervention studies we can do. And we found this quasi-experimental study, which is a subtype of randomized control design. But the only difference between the randomized and quasi-experimental is this study design, quasi, is totally under the control of the patient. This is the only difference between randomized control trial and the quasi-experimental design, ma'am. It's a subtype of randomized control trial where the patient can choose their own decisions.
Okay, okay. Okay, if somebody wants to expand the study for the future perspective, what could be the your suggestions to them for like future aspect of the study?
Yeah, ma'am. To be precise, we have done this study due to our academic restrictions for 6 months only. And we have the limited number of participants, which is 165. And we are also limited the HbA1c level. To verify glucose levels or RBS levels, we need to find out their HbA1c levels. So this was one of the major limitation which we are trying to do in a future perspective. To need to take the HbA1c levels to address and also to do this population. Now we are restricted only with diabetes plus HTN. In future, we also need to do with diabetes plus severe comorbidities also. And also we are going to expand the population size from 165 to a large population so that these results can be credential and reliable, ma'am. This was our future perspectives.
Okay, right.
Yeah. Any more questions, ma'am?
No more question from my side.
No more questions from my side
Yeah.
also, Swati. Thank you. Thank you for the presentation.
Thank you, ma'am.
Thank you so much, Swati. Thank you so much for the wonderful explanation and your bold response. Thank you. And now it's time, once again, chance is given to the first slot member, Deepak Kumar. Are you there?
Yes, ma'am. Sorry
Yeah,
for
now Deepak Kumar from KVK College of Pharmacy. Slot number SVSYCCONRXS48001. You can perform now.
sorry for the delay. Due to some technical issue, I have been.
Okay, that's fine. You can start presenting. Your time limit will be 5 minutes. Make sure to complete it fast. Following Deepak Kumar, Hirija be ready to present. Slot number 5, Hirija be ready to present. Now it's Deepak Kumar's turn.
Okay, ma'am.
Sectional study conducted in 2022 and 2023 on a sample of 1200 households in the 1600 primary sampling center. In each household, the eligible criteria is of 18 to 69 years old. Is it visible to anyone? Hello?
Yeah, you can proceed.
Okay, ma'am. In each household, we have categorized people in this. And we have only taken only one criteria, that is blood fasting blood glucose. That's it. That is less than or sorry, more than or equal to 126 milligrams per day. The main objective of this is to determine the prevalence of diabetes mellitus in the Surapur district or the Surapur years old people. We have identified the factors which are associated with the all those risk factors like the comorbidity conditions such as high blood pressure, high glucose level, and high cholesterol levels. And we coming to the letters, we have conducted and process compares survey conducted in 2022-2023 with sample of 12,000 people in 1600 units. We have conducted just 600 survey units. It has taken 4 to 5 samples per week for each and every people. That's 18 to 69 years old people. Then after data collections included the non-communicable diseases, crackers, cell seeking behaviors, and all those blood glucose and blood pressure, all those. Well, coming to the actual cause of the or actual objective of this study is we all know that diabetes mellitus is a life-threatening disorder cause or life-threatening metabolic disorder in all age group. And the awareness is not at all like what we say, not at all growing in the, or growing in the people. Well, coming to this, we have made that the survey and treatment is preferred mostly as per the prescribed And coming to the results, the prevalence of diabetes mellitus and impaired blood glucose in the Sudapet was 9.3 and 24.5% respectively. Whereas in this we have made about among those diabetes mellitus was about 45.8%, 36.1 were on the or two third of the are using allopathic practice for consultation, whereas others are not using, and 78.8% are using the treatment. Older elders are associated with a risk of diabetes mellitus are 18% more than ever of DM. Conclusion is the prevalence of diabetes mellitus and impaired blood well level of awareness and treatment is still low in the phenotype. I could like to show you some of the graphs. This is the urban percentage and this is rural percentage along with the male and women ratio. Here we can see that the blood glucose past normal blood glucose high in all the groups like 18 to 29, like as 18 to 29, whereas here 50 to 60 is somewhat increasing in the urban age, whereas in the rural age it's also same. You can see here. Here we are discussing it in the gender base, men and women. Hello?
Yes, Deepak.
Yes,
Deepak.
yes ma'am.
Yes, Deepak, you have mentioned their anthropometric measurements, right?
Yes ma'am.
Yes. Could you please tell me which are the two types of anthropometric methods or measurements?
We have taken the blood glucose and the blood cholesterol.
Yeah, I'm just asking which are the main general two classifications for anthropometric measurements. Basic. Yes. Have you heard about static and dynamic measurements?
Yes ma'am.
Yes, that's good to hear. Yes.
So,
So,
say that I just
yeah,
actually
for this patient, you have done with static measurement or dynamic?
we have done the static measurements.
Static. Okay, yes. Yes. And coming to the conclusion, so what you have derived regarding the treatment is patients more dependent on the alternative therapy or allopathic therapy.
Allopathic therapy.
Okay. Have you got any adverse reactions related to alternative medicines? Have you
Yes,
observed?
yes ma'am. We have observed very light, but
Okay.
to the plant medications like you can know you can be say using that pasaru mandu in Telugu.
Okay. Yes. Okay. Thank you, Deepak.
Deepak, what is the future or beneficial perspective of your study? Like how it can benefit it to the diabetic patients?
It is mostly like an awareness program, ma'am, most probably.
Sorry.
I could like to say it is about the awareness of the people who are currently living in the particular region of Sudapet.
Okay. Uh,
So that,
What were your
sorry,
uh, go ahead.
sorry, I could not hear your question due to some network issue. Can you please repeat it again?
I didn't ask a question. You can go ahead with your answer.
Okay. Actually, I've done it for the awareness program as part of public health survey.
Okay, what were the endpoints of this study? Like how you
Sorry,
have, by which parameters you have, like you have assessed with this all the patients?
just we have taken only two parameters. One is the age.
Sorry.
We have taken only two parameters, ma'am. One is
Okay,
the
which were those?
one is the age, and another is the locality.
Okay.
I compared it, mostly the people with very
Okay.
are associated with diabetes mellitus or intermittent fasting blood glucose level abnormalities in the urban areas, mostly due to the lifestyle and the daily day-to-day activities. We can conclude that the people who are located in the urban regions are most likely to cause with diabetes mellitus rather than.
Okay, Deepak. Your next question is, what is the meaning of cross-sectional study?
Sorry.
What is the meaning of cross-sectional study? Hello, am I audible?
Ma'am, you are.
Okay. Is Deepak here?
Hello. Hello.
Yeah, Deepak, what is the meaning of cross-sectional study?
Yes, the cross section study is a type of what we as the cross study is that this study which we have this performed in the subgroup of like what we say means the in the group of people who are currently suffering with the disease.
Okay. No more questions from my side. I think, go ahead.
Yes, Deepak, what are the limitations of your study? What are
Sorry.
your findings regarding the limitations of your study?
Mostly the limitations are the age limitations, ma'am. We have restricted
Oh.
only from 18 to 69 years, first thing.
Mhm. Mhm.
And the region, rural and urban region as well
Okay. Yes.
as we have mentioned here, you can also see my screen. I will be saying, yeah, not this, most probably. Wait, this, is the graph visible to you?
Actually, not visible with that particular slide. Anyway, it's fine.
Wait a second, I will be doing it once more. Then, is it now visible to you?
Not visible. Not visible. Yeah. Yes. Now it's
Okay.
visible. Yes.
These are the parameters we have taken, like age parameter.
Mm-hmm.
We have categorized
Okay.
it into three groups, like 18 to 29 years, 30 to
Mm-hmm.
39 years, and 50 to 60 years, like young age, middle age, and the old age.
Mm-hmm.
And we have taken it in the two, and we have compared it in men and women.
Mhm. Okay. Okay.
These are all those things.
Have you used any medication adherence scales for measuring adherence?
No, ma'am.
Sorry?
No, no.
No.
I don't use
Okay.
it.
Okay. That's from my side.
Thank you, Deepak Kumar. Thank you for your presentation.
Sorry to everyone. Due to some rain issue, we have disconnected. It's as
Okay, we could understand it. Thank you, thank you.
okay.
And moving on to our next participant, Hirija, R.A. Hirija, from the college, Erud College of Pharmacy and Research Institute, slot number SYCCONRX S48005. Hirija. And followed by the next participant, Shweta Pradeep. Be ready. And now over to Hirija. Here you go.
Good evening to all. Is it my slide visible, ma'am?
Yes,
Yeah,
yes,
it
it's
is.
visible.
This is Hirija from the Erode College of Pharmacy.